Afternoon, everyone who's already in the meeting. Thanks for coming along for our learning event today with Healthcare Improvement Scotland, all about mental health and substance use as part of our clinical network webinars. And today's topic is responding to stimulant use. I'm really pleased. I'm Dr. Chanpreet Blaney. I'm the clinical lead and advisor for the Mental Health and Substance Use Project at Healthcare Improvement Scotland. And I'll just be introducing our very welcome speakers today. So we have Dr. Lisa Sholin, who's a research fellow at the College of Medicine and Veterinary Medicine at the University of Edinburgh, and also Dr. Andrew Williams, who's a senior lecturer in the School of Health and Social Science at the University of Edinburgh. And they'll be presenting today about their ongoing work with the Drug Research Network Scotland, and talking about treatments for stimulant use and dependence and the rapid review for policymakers and practitioners that they undertook. Following that, we'll have some time for questions and answers and discussion. And then after that, we have Dr. Katie Brown, who's a senior medical officer in NHS Greater Glasgow and Clyde in alcohol and drug recovery services, who'll be talking about managing cocaine use with co-occurring opiate dependence and her experiences within the Glasgow alcohol and drug recovery services and the role of the cocaine toolkit, which she was involved with developing. So let us know who you are, where you are usually based, and your role in the chat box. I'll also introduce Benjamin McAwee, who's a senior improvement advisor at the Mental Health and Substance Use Programme, with his who will go on to go through a few more housekeeping slides. So thank you all for being here.
Thanks, Chanpreet. Yeah, Benjamin McAwee, Senior Improvement Advisor for the Mental Health and Substance Use Programme at Healthcare Improvement Scotland. Please feel free to introduce yourselves in the chat. And next slide, please. I'm just going to run through some housekeeping slides for everyone. So if you have any technical issues at all, then please get in touch with Amy Donaldson. If you have any issues with your sound or your slides or anything like that. Next slide, please. And here's some instructions. I think we're all quite familiar with Teams now, but just in case we're not, how to open and close the chat panel, how to access some of the accessibility functions. Just to note that your cameras will be switched off during the presentations, but you'll have access to your cameras and microphones during the discussion sections of the event today. Next slide, please. We'll be using the Q&A function. So if you have any questions for any of the panelists today, then please just use the Q&A function that's beside the chat icon up in your tab bar there. And using that, you can vote for any other questions that people have asked that you would like responded to, as well as add your own and add comments to questions. And we'll cover this in a bit more detail later on as well, because we'd like to hear about your experiences in this topic area as well. So there's a discussion section of the Q&A function that we'd like to use later too. Next slide, please. As I said, this will be recorded, but we won't be recording the discussion sections. So presentations will be recorded and shared afterwards, but during the Q&A and during the discussion, we won't be recording. Next slide. And I'll hand back to Chanpreet just to run through the agenda one more time before we get on to the speakers.
Thank you. So I already talked through this before as well, but that's the agenda there in front of us. So first up, we have Dr. Lisa Sholin and Dr. Andrew Williams, both from the University of Edinburgh, followed by question and answers. And then we'll have Dr. Katie Brown speaking as well about the cocaine toolkit and her experiences in NHS Greater Glasgow and Clyde. So we'll have further questions and discussion after Dr. Brown's presentation as well. So thank you all, and I'll just hand over to yourselves, Lisa and Andrew, to start your presentation.
Thank you so much. I'm just going to take control. I think that should do it. Good afternoon, everyone. Nice to see so many has logged on last week before Christmas taking the time to come along to the session. So as Chandpreet said, I'm Lisa Sholin, and I'm here with Andrew Williams. We're both part of the Drugs Research Network and both work at the University of Edinburgh. And then to acknowledge the other author of the review, who's our colleague, Jonathan Brett, who is not in attendance because he is on the other side of the planet. And this was not really in his time zone, but he did a lot of work on this review. It was Andrew and John who did the huge task of pulling this together. So I'm just going to set the scene a little bit and start by presenting a little bit about what the Drugs Research Network is. So it was founded in 2017 and hosted at University of Stirling. The aim of the network is really to foster knowledge exchange between creators, contributors and users of research, and really make the connection between academics and practitioners and policymakers. The hosting moved in 2023 to University of Edinburgh, so we have been sort of coordinating this from University of Edinburgh since last year. So I'm the co-convener together with Dr. Anna Ross. We have Marissa Bruce, who's the coordinator, and then Megan Calman, who's our administrator. So that's kind of the core team, and then people like Andrew are part of an extended sort of team supporting the activities. So when we took over the hosting last year, there's a bit of a reduction in funding available. So it's reduced the staff time and ability to sort of fund projects, etc., a little bit. So we're now focused on knowledge exchange as part of our sort of core activities. So within our sort of regular business as it was, we focus on having 4 seminars or events across the year on diverse topics. 1 annual conference, and then 1 rapid review. Obviously, that's why we're here today. As sort of part of our annual KPI, as it was. We're keen to sort of focus, of course, a lot on drug deaths and the prevention of poor outcomes from substance use, but we're also keen to cover broader issues like policing, medicinal use of so-called illicit drugs. So it's more than just the sort of the harms of drug use. We had an event in November last year where we sort of asked people to come along and share their thoughts on what the priorities for research, for drug research in Scotland is, so to sort of guide our activities and our events. So I will post a link to this report in the chat. I can't do 2 things at once. I'll do that once I'm done. But there were 4 key areas that really came out of this, and that for anyone who's interested in reading this, it is on our website. But of course, harms and drug-related deaths is a key area of focus for many people who came along, but also treatment and recovery, legal changes, and drugs as medicine, as I mentioned, is sort of a broader perspective of the use of so-called illicit drugs. So just to sort of narrow the focus in a little bit on the review, which is why we're here. Obviously, as I mentioned, treatment is a theme of the sort of consultation that we had, or the discussion that we had with people. Cocaine is an increasing issue in both drug-related death data and sort of in surveillance data. So for example, the ASSIST study in Glasgow, and it aims to be complementary to any of the work that Public Health Scotland is currently doing as well. So it was really to try and put something out that would be useful for people at a time where this is a big problem and a growing problem. So just some overall statistics. Amphetamine type drug use is estimated to be around 0.7% globally, with 11% of users being dependent. For cocaine, it's 0.4, with 16% estimated to be dependent. Of course, there's changes to global drugs markets, etc., that are increasing the concerns around stimulant use and associated harms. And in Scotland, particularly, we have seen, for example, through the NESI survey, that there's been an increase in people who inject drugs who are using cocaine, but also within the drugs deaths data, both for cocaine and amphetamines, although amphetamines is much lower than cocaine, which obviously we're seeing as a major problem now. Oops. So the focus of the review was really on the backdrop of the increased use of drugs like cocaine and just the need for exploring treatment evidence. And the aim was really to summarize systematic review evidence of effective treatment options. So we didn't go into individual studies as such. We really went higher level to sort of summarize the systematic reviews, because there's a lot of them out there. What we also did within this was noting emerging areas of evidence where we're still needing to generate evidence, but sort of promising areas. And I think that leaves me to hand over to you, Andrew.
Thank you, Lisa. Let's just see if I can take control. There we go. Really good to be with you. The bit that my introduction didn't give you was that I'm a public health person, so don't come from a strong background in addictions, and that will become clear as we go through this session, but I'm really pleased to be talking you through. So just to kind of go over the methods we use to undertake this review, we really wanted to focus on that, summarising the evidence for policymakers and practitioners, because that's, as Lisa said, a key part of the DRNS is this focus on knowledge mobilisation and knowledge exchange. And we were aware that there had been a number of systematic reviews published quite recently, which meant it wasn't necessarily going to be of great value to go back to the primary evidence. So we did a rapid review of systematic reviews of randomized controlled trials. And as Lisa said, we didn't go back into the primary research. As people involved in this area, we knew that there was an initial group of around 3 reviews that we kind of had at hand. So we took those and went back into the research databases to hunt for any others that had been published. And we were able to identify 9 further reviews by kind of doing what we call backwards and forwards citation searching. So looking around those reviews and searching the databases for any other systematic reviews in this area. So we had 12 systematic reviews in total for the review, rapid review. All of them had been published within the last 8 years, and they were reviewing evidence up to 2023. The nice bit in this piece of work was we found Cochrane had just published a review in this area, and if Cochrane hadn't found a valuable piece of evidence, there's not much chance I was going to find it doing anything else. So it was really good to have a Cochrane review out there. We had 10 systematic reviews, so reviews that just focused on randomized controlled trials, and 3 reviews of reviews. So this is where they've just brought in other systematic reviews to review them. I said on that last slide we had 12, and you notice I've now got to 13. That's because we had one that somehow had included both systematic reviews and primary RCTs in the review. So we do have 12 studies in total. We had some of the reviews only had 8 randomized controlled trials in them, and then that one that had both had 157 RCTs it reviewed and 29 reviews within the paper. And the number of participants included in the reviews ranged from 561 over to more than 15,000. And the reviews of reviews find it quite hard to report how many participants there were, so it's likely we had evidence on a much higher number of people than that. And if you're kind of familiar with this area, you might be aware that some evidence will focus only on one of the stimulant drugs, others will try and focus on a couple of them. Across the 12 reviews we had, half of them only focused on a single substance, and in most cases that was cocaine. So that just gives you a picture of the landscape of the studies we included. Interesting. Okay. Let's see what comes next. Okay. We seem to be missing a key slide on what the results are. Is that right? Let me just check. I've got a slide number that's missing. I might have to talk through it rather than, because it doesn't appear to be there. So in terms of the review findings, and I hope you can kind of picture this in your head. There was only one thing that came up showing consistent evidence of benefit, which is something called contingency management, and that's why it's explained on the next slide. You may or may not be familiar with it. It was also really useful looking across the 12 studies that we found 5 things where there was consistent evidence of no benefit. So these are treatments which had been tried and not found to be beneficial. Number 1 on that list was acupuncture, then the antipsychotics, dopamine agonists, and then 2 kind of broader categories which only make sense where I show you the third category, which is other anticonvulsants and other antidepressants. And obviously that tells you that there's a third group here that are treatments where there's insufficient or inconsistent evidence of benefit. And we'll try and get this kind of slide added back in. Amy, jump on in there.
Hi, Andrew. Sorry about that. I can share that slide if that's helpful.
If you want
it was
to,
missing from that one.
No. If you want to share it, that's helpful.
Okay. Right, I will get that on.
I couldn't visualize this much, but while Amy's doing that, I'll quickly just say that the third group is those where we've got insufficient or inconsistent evidence. So you're going to share it in the chat, Ben, he's put it there. And when you see it pop up, these are areas where things have been tried, but we still need further RCT evidence to demonstrate their effectiveness, or they might drop into the group that has consistent evidence of no benefit with further evidence. Obviously, there's a number of pharmaceutical treatments in there, a number of psychological things, and a couple of more mixed interventions like the matrix model and 12-step facilitation that kind of cover a broader aspect of things. So this is the kind of key takeaway from the review. Amy, if I take control at this point, will it keep going with the slides or not? Or shall I leave
no,
you to
sorry,
take control?
I've opened this on a separate page. Yes, so if you just want to say next slide, please.
Can you go to the next slide then, please? Thank you. Just to explain what contingency management is. So this is a term for rewarding patients for a specific and measurable desirable behavior. And in most of the studies we looked at, it was a negative urine drug test. And the reward has to be something of value to the patient. And we saw evidence ranging from a reward as small as £1.13 a day up to £92 a day. I think that would motivate me quite seriously to do some things, £92 a day. But what some of this tells you, and why I've put a dollar sign on this slide, is that all these studies onto the kind of effectiveness of contingency management come from the US, where obviously you have a very different healthcare system to ours here in the UK. So there's a big question about the effectiveness of this as a kind of part of treatment in the UK. It does reduce treatment dropout according to the evidence. But the next question, Amy, if you click the mouse again, is it's effective at keeping people in treatment, but we don't have any evidence of what the rest of treatment needs to look at. We didn't find anything consistent to point at what treatment needs to look at. So that leaves the question, if we go on to the next slide, of what is treatment for stimulant use. We're in a scenario where there's no replacement, there's no methadone, there's no nicotine replacement therapy for stimulants. So what does treatment look like? And in the evidence, it seems like there has to be at least 3 pieces there, Amy, so I'm going to keep you clicking away to stimulant use talked about in the literature. There's in that top circle, the maintaining treatment, keeping people turning up for treatment, things like contingency management that keep them there. Then there's the treatments we give to provide to kind of manage people's withdrawal symptoms. And then the psychological treatment that helps people manage whatever's going on that's kind of related to the stimulant use. So it seems like you need those 3 things to come together to keep people in treatment, manage the withdrawal, and give some kind of the active ingredient, the psychological treatment potentially in there. And if you click again, Amy, What we didn't find much about in the evidence we looked at was the kind of broader social context or support for people. There wasn't much talk around this in the treatments that were reviewed. What do you need to put in place to support people coming off treatment? And if you click again, that kind of ties into treating the cause of the addiction. What is it that kind of started the substance, the stimulant use, and kept them, got them to a point they were addicted? There wasn't much in the evidence on there. And then the second set of questions, if we go on to the next slide, is around what is a good outcome from treatment? Obviously, with 12 reviews covering many individual studies, we saw studies that were looking at abstinence as the outcome, reduction in use, management of withdrawal symptoms, harm reduction, management of comorbidities, and retention in treatment as a good outcome. And I'm sure there are others you could look at there. There was a big question mark, if you click again, Amy, around how much recording there was of adverse events of treatment and what qualifies as an adverse event of these kinds of treatments. And a kind of question for us to consider in the chat is around how should, go back one, Amy, how should these be measured in practice and research? How should we be measuring these things? Now you can go ahead, Amy, onto the challenges we encountered. Diversity in a kind of negative context here around who it is that uses stimulants. We know these are drugs used by a wide variety of people, and only certain ones end up being recruited into certain studies. So it means you get a study that's only applicable to a certain type of user. What stimulant they're using and how often people are using stimulants has a role to play in causing a kind of diversity amongst the evidence base. And we know that the evidence is particularly lacking in terms of people with comorbidities, such as stimulant-induced psychosis, tend to be excluded from research projects. So we're lacking evidence in that direction. And while we had reviews that covered more than one of the stimulant drugs, we didn't necessarily have reviews that covered people that were taking a stimulant and another type of illicit drug or something else going on. So that's a lacking area. And in general, women are underrepresented within the studies. So we go on to the next slide, Amy. We know that treatment for one stimulant might not be effective for another. So we need to kind of study that cover stimulants and the different treatments out there across that range. There is that range of outcome studies, as I tried to give you a bit of a list. So it makes kind of drawing comparisons between studies quite challenging. We heard about contingency management being a way to keep people in treatment. That's also a challenge for research. If we can't keep people in the studies, we don't get a long-term sense of their outcomes from the research, from the interventions they're trialing. So retaining people in trials is a challenge. And there are big kind of barriers to treatment that I think I go on to in the next slide, including kind of social and financial barriers. And this is where it becomes clear that I'm a public health person, because I very rarely give a talk without including the rainbow model of Dahlgren and Whitehead's social determinants of health, which is my little set of circles here. So the bigger picture things here. So in the reviews, while it wasn't necessarily what we set out to find, we were interested, we had kind of read about the barriers to treatment that people had experienced or reported. And amongst those key ones we kept hearing about were the belief that treatment is not needed for the stimulant use, that people wanted to withdraw without help, to do this without medical intervention, and the kind of embarrassment and stigma around the use of stimulants. And then, as I said a couple of slides back, women are underrepresented in the evidence base, and a couple of specific issues highlighted there was the kind of trauma amongst this group, amongst women who use stimulants that is kind of engaged there, and particular kind of high levels of intimate partner violence impacting on women who use stimulants. And there was a kind of fear of children being taken into care if they reported and came forward for treatment. So if we move on to the next slide, kind of watch this space, what else is there? We didn't go down into individual reviews, but there was a couple of areas that we were kind of aware could be kind of future things coming up. areas where we're awaiting RCT evidence. One is psychedelic-assisted psychotherapy and ketamine-assisted psychotherapy. There's questions about exercise therapy. And then repetitive transcranial magnetic stimulation. That was not one I was looking forward to saying out loud, but things to look forward. And an interesting area that obviously is very expensive, but there didn't seem too much evidence around residential rehabilitation, and there may well be other treatments. This wasn't something that was in our scope, but we just wanted to highlight areas where things were developing. And also, while I've said there is this kind of diversity of outcomes people measure, there is now guidance from the FDA in the USA around how to conduct trials for stimulant use disorder with a set of preferred outcome measures. So that will hopefully make the evidence base more consistent and easy to bring together. Into the last slide from me, I think, Amy. So we'll have a bit of time for questions from you, but I'd be interested to hear, and I see there's been a bit of chat in the chat anyway, based on your experience, what is a good outcome for the people you're working with? And are there treatment approaches that you've seen that help reach that outcome that haven't really been covered in the review? I thought would be good questions. Lisa, do you want to cover the contact details if anybody wants to get in contact with us?
Yes, just to say we're still on Twitter for how long I don't know, but we've moved over to Blue Sky. We're also on LinkedIn. Feel free to email any of us. John is also happy. So John is a specialist in addiction. So if there are specific questions around treatment, he's happy to take questions over email as well. But I also posted in the chat that there's a link to sign up to the newsletter, so you can stay in touch with us and learn about upcoming events, etc. I think that's us.
Okay, that's great. Thank you so much, Lisa and Andrew, for that amazing presentation. It was really interesting, and the Call on Drug Recovery Service, and is going to talk about managing cocaine use and the role of the cocaine toolkit. So thank you, Katie, and I'll hand over to you.
Super. Thanks so much, Shampri. Delighted to be here, and really happy to hear Andrew and Lisa's talk, and thoroughly relieved that there isn't a drug treatment that is now available since we've drawn up the toolkit and not included it. So we drew up a resource for staff to use in Greater Glasgow and Clyde around stimulant use, because it was 2020 that we started the development of our cocaine toolkit, because we were starting to see that increase in prevalence of cocaine use. Around that time in 2020, we were seeing cocaine implicated in about a third of drug-related deaths. Now, as we come into 2024, we're thinking possibly close to half in Glasgow City. So of course, it's incredibly relevant to us. At this time also, a few years ago, we looked at people coming into the service at the front door, and we did an audit of those presenting, and there was problematic cocaine use in over a third at the front door at that stage. And most of these people were also using depressant drugs, seeking treatment, and we were opting for OST. They were known to our service, and so we felt that there was really a need for a resource to look at how we manage that within our current service with the skills and staff that we currently had. We weren't able to get additional resource, but we wanted to see whether we could meet that need within our current resource. And so we went about doing a training needs analysis of staff, and we realised that we did need to upskill in knowledge, training and skills to be able to meet the need within the communities. And so short life working group a stimulant short life working group was set up, which I chaired, and we had a fantastic cross mix of people from within our service and out within that. So we had great support from addiction psychiatrists, clinical psychologists, we had a CBT therapist. We had Katie McLeod from SDF, who's got fabulous experience of frontline stimulant use, particularly at events. She was a fab resource. John Campbell is super in harm reduction in Greater Glasgow and Clyde and was a great asset in the group. And we also had a pharmacy independent prescriber who prescribes in our stabilisation and crisis services, which aren't long-term rehab that Andrew was sort of alluding to, maybe would be an interesting area of research, but they're short-term sort of crisis management placements. And so we had Karen was fab in offering us the support from what they do in these services in the acute phases. So we got the right people together. And before we dive into what the cocaine toolkit's all about, I thought it would be interesting just to ask a few questions of the audience, and maybe just focus your minds around street terms of cocaine use. So maybe just bring it right back down to street level, away from research and into the sort of into the street level of things. So I don't suggest that anyone be inauthentic and try to, you know, use a language that isn't familiar to them, but it's really important that we understand what people are saying to us. And when we met with peer volunteers and folk with lived and living experience as part of this work, we were quite struck by their feedback of how little their workers, their drug workers that they were already engaged with, knew of the street terms, the financial implications, you know, this kind of dialogue that was just, you know, every day to these folk, but really separated them from their drugs worker or treatment service. And so I've just put up some of these questions. I will answer some of them in the presentation, but not all of them. So it might be interesting if afterwards you jump onto the cocaine toolkit and delve a bit deeper yourself. I think that bottom one has maybe not come out very well. I certainly can't see it. So it's just basically, it's as complete a sentence. What is the term for poor quality cocaine at street level? So poor quality cocaine tends to be about £30 a gram. Very widely used at the street level. What is it called to people buying and using cocaine? So I'll answer these later on, but just maybe to focus some minds. So cocaine is from the coca shrub from South America. So all of cocaine in Glasgow, in Scotland, in the UK is imported. So of course, when it's imported, there's a long journey for it to get here, and there's plenty of opportunity for it to be bashed, cut, adulterated, so combined with other drugs or bulking agents. So we always have to be mindful of what else is going on also within that cocaine. But cocaine itself works on the dopaminergic system. You get a big pulse of dopamine, and that gives us the sort of euphoria, increased social bonding, hyperactivity, loads of energy, lack of need for sleep, reduced appetite, disinhibition, all of that those sort of heightened positive effects. It also blocks reuptake of dopamine. So that's dopamine we might use at a later stage. And so there is that two-phase response. You get the euphoria and the positive initially, but afterwards there might be some negative symptoms. So increased sleep, anxiety, dysphoria, low mood, these kind of symptoms, again linked to this dopamine response. So cocaine at street level is normally sold as powder, and powder cocaine is primarily for snorting or injecting because it's water soluble, so it's easy to inject. That powder cocaine will come in different levels of purity, so it'll have different amounts of bulking agent or other things combined with it. So that poor quality £30 a gram is referred to as council in Glasgow. A medium quality, which might be about £50 a gram, is called 50/50, and a high quality cocaine sold at street level is often £80 a gram, and that's called prop or proper at street level. It's also sold very conveniently in 10 or £20 bags for injection, so people are picking this up really easily along with their other drugs. And of course, not only is it sold as powder, but it's sold as crack, so that's a base form of cocaine, and that's made using water and sodium bicarbonate baking soda, and that's perfect for smoking. It can be reduced down for injection, but you would need an acidifier to do that. And then there's freebase cocaine, which is the most pure cocaine, and that's made by freeing the base from the cocaine from the base, and so you can do that using ammonia, and people can do that at street level. It's not often bought or traded at street level freebase. It's the purest form. So we describe a psychological dependence within the cocaine toolkit, and normally that would form 3 phases. So it's quite protracted, but the initial phase will be a few days, and that we refer to as the crash. And that's when you'll get the sort of more acute negative symptoms, exhaustion, sleeping, low mood, irritable, restless. And then you'll move on to a slightly longer phase of withdrawal where you have similar symptoms, maybe less intense, but for a longer period, up to 10 weeks. And then we describe the extinction phase, which goes up to 28 weeks or sometimes longer, sometimes less. And that's characterized really by strong cravings, of course, linked to that dopamine system. And often through this phase, people are using additional drugs. So they might be using depressant drugs for the sort of come down, if you like. So they might be using benzodiazepines or sleeping tablets. They might be using opiates or alcohol in this phase. And people that are using particularly heavily might be using lots of depressants as come down, but actually their primary drug of choice is cocaine. But they're dependent on depressant drugs also, driven by their cocaine use. And again, the peers and folk with lived and living experience that we were talking to quite often were identifying with their primary drug of choice as cocaine, not the depressant drugs that they were receiving treatment for within our service, receiving sort of more robust treatment for within our service. So that was really interesting and relevant to us. But of course, with cocaine being a stimulant, it might mask the effect of the depressant drug, but the risk then of overdose remains. And so you're really in a risky place with folk using uppers and downers. But of course, it's very, very common, and you must tease out why they're using what drugs, etc. And we'll come on to talk about the assessment tool as we move on. So looking particularly at how folk are using their cocaine and the risks associated with the way that they're using cocaine. So, I mean, this cocaine toolkit is primarily aimed at folk that are opiate dependent and on OST, because that's our usual cohort of people. But of course, there's loads of people in the community using cocaine that aren't engaged with our service, but maybe they haven't presented, it's not as problematic for them, and they would normally be using it by snorting it. And so it is really, I mean, this is a useful toolkit for everyone, but it is important to be aware of the risks for the wider population, even, for example, in primary care GPs that might have someone presenting with problems with their nasal septum from snorting cocaine, but that don't ever meet addiction services. So of course, septal perforation is a recognised complication. The lining of the nose is quite fragile. The blood supply is quite fragile, and once you impact on that blood supply and you lose your blood supply to the cartilage, then you're going to get septal perforation, and that's really tricky to treat once it's there. So you definitely want to look out for that before it develops. And that might be someone with like a persistently runny nose, recurrent nosebleeds, these kind of things. And you really want to sort of tune into that and think of ways that you can address that, which I'll come on to. Of course, there's a risk of bloodborne viruses, probably less than we initially thought through snorting, but still the risk remains, and other infections, so localized infections or things like COVID, etc. Smoking, of course, people are using, this was discussed a wee bit earlier, wasn't it, in the chat, people are using makeshift pipes. We can't access recognised pipes yet, but of course folk are improvising, and they're using drinks cans, miniature bottles, plastic inhalers, plastic bottles, and instead of proper gauze or filters, they might be using like a metal scouring pad to burn that crack rock on, and all of these things are setting off particles, and that's before you even consider the crack that's been smoked within it. And so that has terrible repercussions, particularly on the lungs, and you'll maybe have heard the term crack lung, which really is a broad term for a multitude of sins affecting the respiratory system, be it exacerbations of asthma, COPD, pneumonia, respiratory failure, localized damage from ammonia, from that freebase, for example. So crack lung is important to know about and think about and treat. But of course, you've got that localized burns and cuts, etc., from pipes that aren't sort of fit for purpose. And again, we've considered the other route of using cocaine, and that would be injecting, which we're a wee bit more familiar with perhaps in our service, because we work with people injecting heroin, but still incredibly relevant, and as relevant, because of course the action of cocaine is shorter, people are injecting more, and we know that it probably was part to play in the outbreak of HIV in Glasgow, this sort of use of cocaine along with opiates at that time, and the frequency of injecting, the likelihood of sharing needles and paraphernalia might have been at play in driving that outbreak. So of course people shouldn't be sharing, we should be supplying needles and injecting equipment. We also need to be aware that cocaine has a localized sort of anesthetic effect at the vein, and so people are missing hits, they're having localized damage and collapse, abscesses, localized infection. Also, they can't get access, so they're thinking about how else can I inject subcutaneously or into the muscle. You're running the risk of rhabdomyolysis, etc. So important to explore all of that. Yep, so we really wanted to give staff the harm reduction skills in order to engage with people and try and make a meaningful change really early on in those discussions. So we do have the assessment tool, which goes really into depth about how people use, and that's an opportunity to start getting the harm reduction in at an early point. So around about snort, thinking about timing, ideally leaving 30 to 45 minutes between snorting lines, alternating between the nostrils. Obviously, cocaine's coming in different purities, so you want to change the line size depending on the purity of the cocaine you're snorting, both for your physical health risk, but also for the nose locally. Considering dowsing, so rinsing out the nostrils with water after use, really grinding that powder into the finest form you possibly can, so that it's damaging your nose less. So those kind of things, there will be more in the toolkit, but those kind of things to think about. Looking at harm reduction around smoking, so thinking about the pipe that you're using, expelling the smoke from the lungs, so not holding it into your lungs for too long, rinsing those rocks. I said the ammonia is very damaging, so apparently if you rinse the rocks and put them on tea bag, the ammonia will come off and you've less damage from smoking that. And again, using single-use injecting equipment and not sharing, using the smallest needle possible. And we've got details there of needles and how to rotate that, for example, in the toolkit itself. So we come on to think about the physiological and psychological harms of cocaine. It's actually quite easy to consume an overdose, overwhelming amount of cocaine. It's easy to consume a lot quickly, and it stimulates the central nervous system. So it's going to rise your blood pressure, your heart rate, your respiratory rate, your body temperature, increase your risk of heart attack and stroke, chest pain, numbness, weakness, and these kinds of symptoms. So, and again, working with the peers and folk with lived and living experience, almost everyone in the room had had a psychotic episode, and there were a few folk that had MIs in the room as well. So really underlined the impact of the physical health harms associated with cocaine for us, drawing the toolkit together. Of course, disinhibition and risks around sexual intercourse, the play it can have on women's menstrual cycle and infertility, the risk to mother and baby if a pregnant woman is using cocaine, are all key. Thinking about what else someone's taking and using, I know I mentioned, but alcohol is a huge factor. We see, of course, people using OST, around about 1 in 10 are alcohol dependent. And if we're seeing maybe 30 to 40 to 50% of these people using cocaine as well, I mean, the cumulative risk there is huge. So cocaine allows you to drink more, so you can drink more without being intoxicated, but of course you've got a ceiling there, and alcohol toxicity can and does happen. It produces a third chemical, cocaethylene, and that third chemical increases the euphoric effect of cocaine, increases the duration of that cocaine, but also increases the toxicity to the cardiovascular system, so increases the heart rate, increases the blood pressure, and increases the risk. But that's because of the increased euphoric effect. Alcohol is quite often a driver for cocaine use and quite often a trigger when people even have been abstinent from cocaine for a while. So really worth knowing that. Just jump on. So again, we really wanted to dial down on the implications of cocaine for our people using OST, and Anna Fletcher had done work already in Edinburgh around this, and so Anna brought a great wealth of experience to the group. I don't know if Anne's here, but consultant psychiatrist working in NHS GGNC, and so she was able to give us information that OST, starting OST can reduce all drug use, global drug use, but particularly heroin, but also cocaine, and so not to delay starting, because sometimes people had an initial feeling that maybe we should stabilize that cocaine use first, and the answer was no, we should get people on OST, be mindful of the cumulative risk, but get people on OST, and that can have a positive impact. Of course, ECG is incredibly useful, and cardiovascular risk assessments incredibly useful in folk using cocaine and depressants and thinking about starting OST, but don't delay starting the OST for an ECG. If we could get it at the outset, fabulous. But if it was going to delay treatment, then we really do need to balance the risk and benefit of that. We, of course, need to be mindful of the QT prolongation with methadone in particular, and buprenorphine might offer us less respiratory depression and less QT prolongation, but is buprenorphine the right substitute treatment for that person? You know, have they got crippling anxiety? Have they had buprenorphine in the past and not liked it? Have they dropped out of treatment? Are they difficult to engage? So all of these things you need to consider, and it still is an individual choice as to which opiate substitute treatment you use. Again, we saw that people from studies that people in the higher end of the treatment range did better and reduced their cocaine use more when also co-prescribed OST. And so we do still try to optimize that dose. Of course, we'd be mindful all the way along, but we try to optimize that dose. We review the other medications. So of course, being mindful that there can be an interaction between SSRIs and cocaine, and also an increased risk of bleeding with citalopram and cocaine, and citalopram and prolonged QT. So again, just being really mindful of that, of the drug use, polydrug use that the person is taking, and the importance of revisiting that regularly. What's happening, what's fluctuating. So responding to a mental health crisis, typically the crisis is short-lived. As the cocaine wears off, often the crisis resolves. Normally we need a crisis assessment rather than a full mental health assessment. It's very difficult to do a full mental health assessment on someone that is very intoxicated. And so if someone is very overstimulated, so we're talking about, you know, hyper-aroused, rigid, increased reflexes, superhuman strength and energy, you know, profusely sweating and overheating, we do really need to think, is this a medical emergency? Is it a serotonin syndrome? Is someone delirious? Do they need acute medical attention? If they do, you know, great, get them into the acute side. But if we can de-escalate, then we will. And we've got a section in the toolkit about de-escalation, because we might have to do that in our own service or even in the person's home. So it's all about empowering staff to have the skills to manage an acute presentation that isn't a medical emergency. So making the person safe and feel safe, establishing trust, grounding techniques. So of course, what can you see, hear, smell, taste, feel, for example, and trying to really ground someone in that moment and reassuring. Often people are aware of risks of aggression or violence, but in actual fact, quite often during the crisis, someone is terrified and the aggression might come through fear. And so in the group, we had lots of discussion about how to word that actually in the cocaine toolkit, and stepping away from this aggressive vision to actually someone that's very fearful, and how can we reassure someone in a safe environment. But of course, chronic use or heavy binge use can lead to protracted, prolonged or relapse of mental health conditions or chronic mental health conditions. And so they may need a further mental health assessment during that phase when the crisis has settled. Particular things to look out for are delusions or hallucinations that are tactile. A delusional parasitosis can occur with cocaine use. So someone feels like they've got bugs or they're infested, can occur without really any other mental health symptoms, and can quite often actually present in primary care and not to mental health services, because someone is just actually physically feeling like they're infested, and they might even bring evidence of that to the consultation. So being mindful of these specific symptoms are key, and onward referral are important when required, and we will do that. And a cornerstone of treatment, of course, other than empowering our staff with knowledge, harm reduction advice, is of course psychosocial interventions. And so we looked really at three-pronged approach, and people would tend to move through these three stages. And this leans very heavily, or is taken from NHS Education for Scotland training around core skills, Laura Freeman's work. And so in Glasgow, lots of our staff have had core skills training historically, or will have access to it in the future. So we wrote it for that cohort of staff, and we would really encourage people to go on the core skills training with Ness, and then, you know, delve into this. But of course, we put it in the cocaine toolkit for folk that haven't had yet or don't have access to that. And it focuses around motivational enhancement, developing control over impulsive behaviour, goal setting and relapse prevention, developing a rewarding lifestyle, which I think someone was commenting on also earlier. And I have a paper copy of the cocaine toolkit here, and in the back of the toolkit are all of these worksheets that can be printed out and used with people again and again and again. So it's a usable resource for staff to use with people engaging. We also have a brand new assessment tool in here that I mentioned earlier. So Katie and John really together, we recognised as a group that there wasn't an assessment tool available for cocaine use. And so they drew together an assessment tool. It is a few pages long, and it's meant to be used in discussion with the person, and it triggers all that harm reduction intervention along at the same time. But it really dives into the drug use, the patterns of use, the types of cocaine, how it's used, hygiene settings. It even delves into sort of the drivers for use. We talk a lot about mental health and physical health, sexual health, risks of infections, and more. So it's a fabulous assessment tool that can be used over multiple sittings again and again and again, but it's a great prompt for staff to use with people to really properly explore their cocaine use. We presented a poster, with the opportunity to present a poster in Glasgow when the International Network of Health and Hepatitis Care was in Glasgow. We presented a poster, which I think doesn't really translate very well into a slide, but you can see there like examples of crack pipes that we've included in the toolkit for staff, and we just want to say a special thanks also to the peers and folk with lived and living experience that helped us along the way. We had a couple of facilitated focus groups. We also managed to trial the assessment tool and the whole cocaine toolkit with people, and we got fabulous feedback from folks. That was a really great experience for us all. We gave a paper copy to every member of staff in Glasgow Addiction Services. So for those that don't use a computer, these people do still exist. We gave a physical copy to everyone. We're so keen that people use it. You can also get it online. Anyone can get it online. You guys can get it online. Just Google NHS cocaine toolkit. You'll find it. There are a few ways to get there, but you'll get there fairly easily. We did look at a staff survey this year of folk that have had the toolkit. I can assure you they've had it. 66 people responded electronically voluntarily. 67% of them had heard of it. Sadly, only 26% identified with having using it. I'm telling myself more probably did use it. They just weren't aware that they'd absorbed that knowledge. Anyway, it told us quite clearly that we need to do organised staff training around this, and that is in the pipeline. We're developing that currently, and not on the slide, but we have had some early discussions about developing an app similar to MyPsych. So that's in discussion. Oh, there's the answers to the quiz for those that were interested. I'm sure you all knew that anyway. And for more street terms, please do go to the toolkit and you'll have a whole new level of conversation with people. And yeah, just want to open it up for questions. Thanks very much for listening.
Thanks, Kate. That was a really, really helpful and interesting presentation. I think the toolkit, it just looks so helpful and very practical, and gives guidance for what to do when you have an individual in front of you that's really struggling. So I think it's all really, really positive work. What I would say is I think giving a paper copy and disseminating it like that is actually a huge undertaking, especially in a health board as big as Greater Glasgow and Clyde. And I think the challenges with that, will be experienced all across the country, when they have so many staff and they're located in different areas. So yeah, it's always a work in development, I think, with such huge staff numbers, to sort of develop training and ongoing learning, and sometimes just revisiting things all the time, because refresh is as important as initial learning. But I think it's really, really amazing work. So thank you for that.